I would like to introduce to you this morning to the beautiful and mountainous country of Swaziland. Actually, Swaziland is the smallest country in the southern hemisphere. It's embedded into the Republic of South Africa and is bordering Mozambique to its east. Tiny amount of population, 1.1 million, lots of young people, 52% are less than 20 years old, and the vast majority of the population is living in rural areas, actually not in the typical village structures we would know, but in widespread settlements, and that has its huge impact on transport and access to care. The economy is largely agriculturally driven, and even though Swaziland has been ranked as a middle-income country, 69% of the population is living in poverty with the definition of less than $1 per day. But as tiny and beautiful Swaziland is, as tremendous are its problems in regard to the HIV and TB epidemic. 26% of the adult population is infected with HIV, and even worse, the HIV prevalence in women attending antenatal care is 39%. And every year we get 7,000 new HIV infections on the top. And not surprisingly, TB exploded over the last year, starting already with a high incidence rate in 2000 with 800 per 100,000 population. And it's now the highest incidence in the world with 1,275 per 100,000 population. And the TB HIV co-infection rate is over 80%. And these dramatic figures had its huge impact on the population structure. Actually, the population in Swaziland is shrinking. That's the only country on the African continent where the population is decreasing, and the life expectancy crashed down from former 62 years in only 2 decades to today 33.7 years. That's actually the lowest life expectancy in the world. And due to these dramatic figures, MSF OCG decided in 2007 to support the Ministry of Health in its fight against HIV and TB. But when we looked at the treatment outcome figures for the 2007 cohort, we found quite shocking treatment success rates of only 58% of treatment success in new sputum smear positive cases, and only 37% in those who had been treated before. And because of that, that triggered us to say, okay, we do have to have a closer look on the drug resistance situation in this country. And we started looking at this with getting an idea about the magnitude. What is the prevalence of drug-resistant TB in this country, in particular MDR, TB multi-drug resistant, that in TB is defined as resistance to isoniazid and rifampicin, the most two powerful drugs we do have in our fight against TB. So together with the Ministry of Health and the Supranational Reference Laboratory in Borstal, in 2009 we conducted a nationwide drug susceptibility survey. We collected 800 subsequent samples. 633 finally could be processed, and out of those we found 440 fully susceptible and 122 MDR TB. The rest was PDR TB. And the outcomes were quite shocking, actually. We found a prevalence of MDR TB of 7.7% in new cases, and new cases are those who never received treatment before, and 34% in retreated cases. And in terms of absolute numbers, that meant that we had more than doubled the numbers of expected patients. And also alarming was the fact that we found an 8-fold increase of MDR TB in new cases compared with the figures in 1995 when the first drug resistance survey has been done, and only a 4-fold increase in previous treated cases. And that has to ring a bell, because if someone who has never been treated before for tuberculosis all of a sudden comes up with multi-drug resistant, that means something in terms of transmission. And as you might know, the common concept is that multi-drug resistance occurs through resistance amplification from a patient who is initially sensitive to all the TB drugs. So we felt to know about the magnitude is not enough. We do need to have a closer look. What are the determinants of this drug resistance epidemic in Swaziland? So we decided to conduct a subsequent study and look at the factors associated with MDR-TB infection in Swaziland. And we wanted to come to this from three angles. First, we asked ourselves, are there patient-related factors, such as age, sex, and most importantly, of course, the HIV status? Or are these institutional-related factors that allows an increased transmission or resistance amplification? Or are these maybe strain-related factors? And this idea didn't come out of the blue. We know from the literature that there are certain strain families, notably the Beijing strain and the Latin American Mediterranean strain, that has been found to be strongly associated with MDR-TB and MDR-TB outbreaks, mainly in Asia and Eastern Europe, but also in South Africa, for example. You might remember that there was this tremendous XDR-TB outbreak in 2006 in KwaZulu-Natal. That's actually the province that is connecting to Swaziland in the south. And this XDR-TB outbreak was driven by a lamb strain. So the hypothesis is that maybe the genetic constellation of a strain family in itself drives the strain to be more vulnerable to become MDR-TB or has to enhance the capacity for transmission and dissemination. So what did we do? We conducted a case control study, and we took advantage of the fact that we had gathered all this sample during the 2009 DST survey. And we took all the MDR-TB strains we had found and defined being MDR-TB as the case and compared it with 122 samples identified as fully susceptible. And then we collected patient variables we wanted to compare amongst these two groups. And finally, we conducted the so-called genotyping or phylogenetic classification to look at what strain families are in this country. Are they associated with MDR-TB? And if so, not if so, but and then looking also on the cluster status. So what is a cluster? A cluster is defined as at least two strains that are 100% identical to each other, genetically identical. And the hypothesis is that if I'm carrying a strain, and he's carrying the strain, and we both have exactly the same strain, there must be an epidemiological link. So either I gave it to him or he gave it to me. And that has something to do with transmission, so we are using the level of clustering as a proxy for transmission. What did we find? We found a positive association with MDR-TB in the multivariate regression analysis being a previous treated case. And that was not so surprising because we know as more often someone does get TB treatment, as more prone is he to do resistance amplification and drive towards MDR-TB. But the big surprise was the level of clustering. Amongst the entire cohort, we found a level of clustering of 64%. And then when we compared MDR-TB group with susceptible group, we found a highly statistically significant, stronger cluster level in the MDR-TB group. 90% almost of the strains in the MDR-TB group were in clusters, compared to only 38% in the control group. HIV, that was a small surprise, was not found to be associated with MDR-TB, even though it showed a strong trend. And amongst the lineages identified, we could find 7 lineages. And yes, we found Beijing, and yes, we found Lam, but both were not at all associated with MDR-TB. That was a second big surprise. They were even statistically significant negatively associated with MDR-TB. And instead, we found the X and the S type strain that have never been reported to be associated with MDR-TB strongly in the MDR-TB group. And another surprise was that we found big clusters in the MDR-TB group, but only small clusters in the susceptible group. Here you can see that very nicely. In the upper picture, All the colors are representing a strain family, and the size of the circle represents the size of the cluster. And you can see the X and the S type. These are the big two clusters, and translated into MDR-TB versus susceptible, they are all MDR-TB. Or look at this picture. You can very clearly see that in the MDR-TB group, there is a clearly reduced population diversity among the MDR-TB strains compared with the susceptible strains. And again, the X and the S type, they show a very strong clonal expansion and thereby mediating the MDR-TB transmission in this country. So what can we conclude? We can very clearly say that MDR-TB in Swaziland is largely driven by transmission, and that is a really new component for us which we have to take into account. And we can even say that within the previous treated group there must be a substantial amount of transmitted MDR-TB. Two completely unknown strains show a strong clonal expansion within the MDR-TB group, and Beijing and Lam did not. And so the hypothesis that genetic determination is more prone to develop into MDR-TB might be wrong. Maybe we have to redefine our hypothesis and say that because a strain becomes MDR-TB, he changes his behavior and start to show a strong clonal expansion and dissemination. Maybe that's not the case. Maybe we have to acknowledge that our methods at the moment are still too rough. And maybe if you look further into the Beijing and the Lam strain, we will find sub-branches. The one is more aggressive, the other one not. This has to be further followed up. There were, of course, study limitations like usual. First of all, a case control study design has a limitation in itself because it does not represent the real population. And also, we only compared MDR-TB with fully susceptible, but we kept outside the PDRs, and that can have a huge impact. And also what is most probably a problem is to handle the MDR-TB as a group, as a homogeneous group. MDR-TB is defined as a resistance to isoniazid and rifampicin, but there are lots of other resistance patterns possible, so that makes it in fact a very heterogeneous group. And that's the same for the previous treated cases group. They are very heterogeneous situation. And then, of course, we took the data and also the samples from the DST survey in 2009, and this survey in itself had its limitations, so we carried on the limitations to our study. And for example, one very important information for us was missing, and that was the episodes of hospitalization. Maybe all this transmission happened in 1 or 2 hospitals, and then it has nothing to do with the strain characteristics. So the take-home message is very clearly we have to control better transmission. And this we have to do through a policy shift towards more infection control at all levels, most probably in a high-incidence setting like Swaziland. It is not enough to only control infection at a hospital level. We have to go to the prisons, we have to go to the military zones, we have to go to schools, we have to go to public gatherings, we have to go to buses, and so on and so on. So infection control has to happen at all levels. B, we have to really look and be better in early detection, but early detection of TB is not enough. We have to enroll our patients a priori into adapted treatment, into MDR-TB or drug resistance treatment. Finally, we have to make sure that those patients with symptoms have access to care, and we do this in Swaziland through a stringently implemented decentralization and task shifting program. And the last point is we do have to implement, and we did implement, preventive measure with isoniazid preventive therapy. But one thing has to be very, very clear. We will never win this game if we don't get better drugs and better drug regimens that are less toxic and need to be more effective. And with this, I would like to thank all people who had contributed to this study, and thank you for your attention.